Dr. Saravanan, sir.
Sir, now we can start, sir.
Yes, sir. PTS, sir. No problem. Good evening, sir. On behalf of Tamilnadu Orthopaedic Association, I welcome our esteemed faculties.
Okay, sir.
Yes, sir. Professor Anil Mathew and John Santoshi for this TNOA PG teaching program. I welcome the postgraduates. As I mentioned in the chat box, this is a topic which is sometimes missed by the postgraduates. When you study for a postgraduate examination, this may not be that much. You may consider this may not be important. But thing is that you may face this type of clinical cases commonly in your OPD. It may cause a dilemma in your diagnosis. You may face it regularly on a weekly basis. You may see these cases, how to proceed. And you may not have a full understanding of the electro-diagnostic test. Many of the entrapment syndromes we see in your common OPD. So this is a time to listen and learn from an expert. Both we have a fortunate to have a very experts in this type of cases. I welcome Professor Anil Mathew as well as Dr. John Santoshi. Professor John Santoshi is Additional Professor of Orthopaedics in All India Institute of Medical Sciences, Bhopal. He is graduated from Nagpur and then went to Delhi DNB Ortho. He finished his MS Orthopaedics. He did his fellowship in hand surgery from CAC, the Paul Brand Institute of Hand Surgery from CMC Vellore. He has worked across this country, mostly in teaching institutions, starting from JIPMER, AIMS, CMC Vellore, and various teaching institutions. That shows his interest in teaching. He has got a good number of publications, about 25 to 30 number of international as well as national level journals he has published. He has interest in basic science, hand surgery, limb reconstruction system, as well as surgical site infections. He is a reviewer of national as well as international journals. We are happy and pleasant to have Professor John Santoshi as a moderator for the session. I welcome, sir, and on behalf of TNOA, I invite you to start the proceedings, introduce our speaker, Professor Anil Mathew, and go ahead with the proceedings. Thank you, sir.
Good evening, sir, and thank you very much for the kind words. I thank Dr. P.T. Saravanan and the TNOA team for giving me this opportunity to moderate this session. It gives me immense pleasure in introducing today's speaker, Dr. Anil Mathew, who is Senior Associate Professor in the Paul Brand Center for Hand Surgery, Christian Medical College, Vellore. Dr. Anil completed his MBBS from Bangalore Medical College and then Diploma and MS Ortho from the Christian Medical College, Vellore. He completed the Paul Brand Fellowship in Hand Surgery from Christian Medical College, Vellore, and then subsequently also did the Fellowship in Hand and Reconstructive Microsurgery from Halifax, Canada. After completing MS Ortho, Dr. Anil joined as faculty in the Department of Orthopaedics at Malankara Orthodox Syrian Church Medical College, Kolancheri in Kerala. And then he joined CMC in 2011 completed his senior training fellowship from prestigious centers from Sweden, Switzerland, and USA. He has done special training in tetraplegia reconstruction, reconstructive surgery, advanced nerves research, and also peripheral nerve surgery. He has performed more than 500 brachial plexus surgeries and also about 125 free flap surgeries, including free functional muscle transfers. Dr. Anil is trained in electrodiagnostic analysis in patients with peripheral nerve and brachial plexus injuries. And I must applaud the TNOA for choosing him to deliver this class, as Dr. Anil not only performs the electrodiagnostic tests himself, but also operates the patient. So he gets this correlation between the electrodiagnostic and the intraoperative findings, which lacks in our usual practice. He has a number of publications in peer-reviewed national as well as international journals. His present area of research is radiology of the brachial plexus injuries and outcome of perforator flaps. He has served as executive member of the Indian Society for Surgery of the Hand. I'm sure the postgraduates will have their concepts as well as their doubts cleared on this important topic. With this, I hand over the proceedings to Dr. Anil Mathew.
Thank you, Dr. John, and thank you, Dr. Suresh, Dr. P.T. Saravanan. I would like to firstly thank the members of the Tamilnadu Orthopaedic Association for inviting me for this particular program. And like Dr. Suresh said, this is a topic that is generally not mentioned in our books. It's something which I had to go and learn for myself from different people so that I actually understood what is going on before undertaking nerve surgery. So without further ado, I'll go on to my presentation. So today's talk is a very basic talk on electrodiagnostics and nerve injuries and compressive neuropathies. I will try as far as possible not to use any kind of or too many numerical values within the presentation so that you don't get confused. What I'll try to do is give you an overview of electrodiagnostics we use in both compressive neuropathies as well as electrodiagnostics in nerve injuries. They're kind of related. So bear with me for the next half an hour or so and I'll try and finish it. And I welcome any questions at the end of it. So Dr. John is a friend and colleague of mine. I've known him for almost 20 years. We did our MS Orthopedics together. And he's a hand surgeon and an orthopedic surgeon. Like Dr. Suresh mentioned, he's from All India Institute of Medical Sciences in Bhopal. We keep in touch. And I'm grateful that he introduced me as a speaker for this session. So when we look at peripheral nerve injuries or peripheral nerve pathologies, the three things that are very important is, one is to localize the lesion to find out where in a nerve the problem is, to estimate the extent or the severity of the problem, and then choose what type of management we should do for them. So if a patient actually comes to us, to our outpatient clinic with peripheral nerve palsy, obviously we have to take an accurate history, and the history as far as an injury is concerned, we have to find out what the mode of injury is, whether the patient had an open injury, where there was a laceration or a soft tissue loss which caused a nerve injury, or whether it was something like a compression or a traction which resulted in a closed nerve injury. And the next important question is to ask him, how long since you've had this injury? Because that is very important in determining what kind of management we're going to do for this patient. Many times in large tertiary referral centers like ours, we find patients have been already operated elsewhere, and then they come to us with a nerve pathology which is either not managed primarily by the surgeon, or the patient is unsure whether that nerve was dealt with in the primary surgery. So often the clinical diagnosis of a nerve pathology is kind of simple because it is like mathematics. If you follow a very systematic clinical examination, you can pinpoint which nerve or nerves are involved, where the pathology is, and to a fair degree, what the extent of the pathology is. Now, the clinical exam, as far as the peripheral nerve injury is concerned, it will actually define muscle weaknesses based on different patterns. And the patterns of weaknesses can be related to a root. It can be a trunk level of the brachial plexus. It can be a cord level injury or any of the branches like any peripheral nerve injuries. Similarly, each of these locations will produce a sensory loss which has got a particular pattern which is also indicative of where the injury is. So what we do in a center like ours is we do what is called as a motor muscle charting. Every time the patient presents to us and sees us in the clinic, we send him over to a person who does an independent assessment, and he will chart down all the muscles which are weak and in an MRC grading from 0 to 5, and he will mark it in boxes. And that will give you a fair idea of what nerve or cord or a trunk or root or roots are involved when we finally mark this chart. To do an objective sensory charting, we use those filaments which are seen on the right top corner. These are basically kind of a ruler which has got thick plastic filaments which can bend when you apply pressure on it. So each of those filaments are of graded thickness, and the thinnest filament will apply a force which is roughly equivalent to about 20 micrograms or 0.02 grams. So each of these filaments will tell you how much of objective sensory loss the patient has based on different points of sensation. Another important testing we do is what is called as a 2-point discrimination. We can do it simply with a paper clip, or you can use this device called the discriminator, which can tell you which is the shortest 2 points which the patient can actually perceive. Similarly, the assessment goes on to have a vibration testing, which is done with a standard 128 and 256 tuning forks. Now, following all this, usually the diagnosis is relatively clear, and often the investigations that follow will be a nerve conduction test and an electromyography, and appropriate imaging. It can be radiographs if the patient had a humeral fracture and a radial nerve injury. And usually the best investigation tool in peripheral nerves, at least, is a high frequency ultrasound, where we use an 18 to 20 megahertz probe, which can kind of very well delineate the fascicles within a nerve. And thereafter, an MRI, which is usually limited for root level, spinal cord level, and brachial plexus injuries. So the MRI has limited role for finding peripheral nerve injuries in the periphery of the body. That means in the limbs. So this is a diagrammatic representation of a nerve in serial magnification. So the A in the picture actually represents an axon. And if it's myelinated, it's surrounded by this black myelin. The myelin itself is enclosed by the Schwann cell. And what you see in blue there is the Schwann cell nucleus. And if it is a myelinated cell, if it's a myelinated axon, one Schwann cell will wrap the axon at different points. So you have the Schwann cell, which are present serially, and the space between them will form the nodes of Ranvier. And each of these Schwann cells will enclose a myelin, and the myelin in turn will enclose the axon. Now, each of these myelinated nerves, axons, and unmyelinated nerve axons sit in a matrix, a connective tissue matrix, which is represented by the blue color there, light blue color, which is called the endoneurium. And many such nerves together are enclosed within a sheath, which is called the perineurium. So this many such perinuria combine to form what is called as a peripheral nerve. And the area between the perinuria is called the internal endoneurium, while the area, the sheath which covers this whole nerve is called the external epineurium. So that's a cross section where you can see the same picture. The E represents the endoneurium, the A the axon, the M the myelin, the P is the perineurium, and the EI and the EE represents the internal and the external epineurium. So there are two people who actually classified nerve injuries. We know that there's a classification by a person called Seddon, which is probably a good practical classification, while Sunderland classified the same thing at a kind of a microscopic level, you can say. So Seddon said there are three types of injury. One, there is neuropraxia, axonotmesis, and neurotmesis. In neuropraxia, essentially there is a conduction block. Axonotmesis, the axons are cut, but the nerve tubes are relatively intact. So the probability of the nerve regenerating through those nerve tubes are high, and probability of recovery is also high. Neurotmesis is actually when the nerve is completely lacerated, where the nerve tubes as well as the axons and all those tissues inside are completely cut. Usually it means that the cut nerve ends will move apart, and once they move apart, they will not spontaneously recover. Sunderland basically broke this down, and what he said is neuropraxia is essentially focal demyelination. A segment of the nerve loses the myelin, but the axons are relatively intact. While axonotmesis per se can be of three types, grade 2, 3, and 4, based on how much of injury is there. So a grade 2 injury is basically focal demyelination with some axonal loss. Grade 3 is axonal injury with demyelination plus some endoneural injury, while grade 4 is axonal injury with endoneural injury as well as perineural injury. And grade 5, all of the above, including an epineural injury. Susan McKinnon, advanced researcher and nerve surgeon who works in St. Louis in USA. I had the opportunity to work with her for about a month. She actually said most nerve injuries, at least traction nerve injuries, are not any of these particular grades, but they are a combination of these grades. I'll come to that. So if you look at this picture, you'll notice that this fascicle has everything intact except that the myelin around it is gone. So this is typically a Sunderland type 1 injury, or what Seddon would have called as a neuropraxia. So when the axons are also cut and the myelin is also gone, while the endoneuron is relatively intact, the connective tissue within the fascicle is relatively intact, it is called a type 2 injury. And that is what we call as a true axonotmesis, because once a nerve begins to regenerate, because the nerve tubes are still intact, the possibility of the nerve or the muscle recovering is very, very high. Now, in type 3, there is a damage to this intervening connective tissue matrix, which is called the endoneurium, along with the myelin and the axon. There is a possibility that spontaneous recovery may or may not occur. Now, further down, in a type 4 injury, the perineurium, which encloses the fascicle, is also injured. And this is a type 4 injury. And the chance of a spontaneous recovery following a type 4 injury is kind of very remote. And a type 5, of course, when the whole nerve is disrupted, like a neurotemic injury. So that's what I summarized. So if you have a grade 1 and a grade 2 type of injury, the possibility of you getting a spontaneous recovery is high when you have a neuropraxic injury. While in a grade 2 injury where only the myelin and the axon is damaged, you will have a recovery, but it will take time because the nerve has to regenerate through the nerve tubes to reach its muscle or the sensory end organ to get back function. Grade 3 onwards, the chance of getting spontaneous recovery is very, very poor. Grade 3 is a maybe, grade 4 and 5, almost no chance. So what really happens in a type 1 injury? A type 1 injury is what we see in most compressive neuropathies or any kind of compressive injuries like a Saturday night palsy. So there is a focal demyelination of a segment of the nerve, which results in a conduction block. And what is typical about neuropraxia is there is no axonal degeneration. So if you follow up this patient, typically he does not have the Tinel sign, which is seen in nerve regeneration. And normally recovery should occur spontaneously over 6 weeks to 12 weeks. The rest of the injuries, namely Sunderland type 2 to type 5, or axonotmesis and neurotmesis, can simply be put under a group called nerve transection. So what is common in all of these nerve transections is all of these injuries will have an axonal damage where the axon distal to the point of injury will undergo what is called a secondary degeneration or Wallerian degeneration. Along with the axons, the myelin will also degenerate and it will undergo apoptosis. So that's a picture where you can see a normal axon surrounded by a myelin, which in turn is enclosed by this Schwann cell. And that large circular thing is the Schwann cell nucleus. The picture on the right actually shows the same myelin and the axon undergoing degeneration. In all cases where there is a nerve transection, the nerve attempts to regrow and nerve sprouting will occur, usually from a point of the axon, usually above one node of Ranvier, above the level of the injury. There is a proliferation of the Schwann cells. The Schwann cells will become like phagocytes. They will eat away all that small nerve fragments which are present, and then go on to eat away all the myelin bits and the axon fragments which are present, and then leave behind empty nerve tubes through which new nerves can grow. So reinnervation will typically occur if these nerve tubes are relatively intact. So that's a type 2 Sunderland injury. Now, when we talk about electrodiagnosis, there are 4 different components in electrodiagnosis. I will not talk about everything. There are nerve conduction studies. There is something called as electromyography. Another thing is called evoke potentials, which may be sensory or motor. We use some electrical studies during surgery, especially when we're doing brachial plexus injury, which we call as intraoperative nerve studies. But today's talk will be limited to nerve conduction studies and electromyography. Now, this is the setup we have. It's basically a small machine which sits at the bottom. The rest of it is just a computer terminal. You can use a laptop also. It has some stimulating electrodes, and you'll have receiving electrodes, which are not shown in this picture. So nerve conduction studies usually is of 3 types. There is something called a sensory compound nerve action potential. There is also a motor nerve action potential and a mixed nerve action potential. So let's talk about the sensory compound nerve action potentials, also called as SNAPs. So what do we actually do in SNAPs? So as seen in this picture, there are 2 reading electrodes which are marked as E1 and E2. There is a grounding electrode marked by that green in the middle of the palm here. And we have a particular stimulator which has both a positive and a negative. Why a positive and a negative? The nerve will actually propagate the action potential from the negative side. So that means if I put the negative on the distal portion, the nerve action potential will only propagate distally. If I reverse the polarity and put the negative on the proximal end, then we'll find that the action potential will actually go towards the spinal cord. That's why you have a dual stimulator, which we generally use. So we give a stimulus, and then on the oscilloscope or on the monitor, we get to see this waveform. This is typically a sensory nerve action potential. As the electrical current passes through the digital nerve between these 2 reading electrodes, you get this particular waveform. So what the examiner actually does is, he does multiple such stimulus once he finds out the correct level of the stimulation that is needed. And then the computer will kind of average out the values for us and tell us the amplitude and the latency and so on. So the time it takes from the point of stimulus to the formation of the wave is called latency. Simply, it's called latency. Compound motor action potentials is very similar to the sensory nerve action potentials. The only difference being the reading electrodes are kept on top of a muscle. In this case, the abductor digiti minimi. Same thing, you do a stimulus, you get a waveform. So you get the stimulus, there is some latency, and then you're going to get this waveform. Now, what is electromyography? Although it sounds very daunting, electromyography simply means measuring the voltage of a muscle. In other words, if you go back to your 12th standard physics, you're just connecting a voltmeter to a muscle. So to have 2 parts to be measured, we put one grounding electrode anywhere on the body. It's just a Velcro strap which we can strap around one of the limbs. And since we want to measure the voltage from a muscle per se, the best way to do it is to use a needle electrode like that shown in this picture. So you pass this needle and pass it into the muscle, and then you start measuring the voltages. So in electromyography, the technician or the person who's actually doing the test is going to look at three things. As you pass the needle into the muscle, you will find something called as an insertional activity. So the muscle basically says, ouch, you're poking me. So you'll get a waveform as you're passing the needle into the muscle. Then you leave that needle behind and see what is the waveform or the voltage that happens at rest. And then you ask the person to use that muscle voluntarily. And then you measure the voltages of that. So we look at each of these. So as you insert the needle into a muscle, you get the small waveform, which is called as an insertional activity, which is present in all muscles, normal muscles. So this is called as insertional activity. And when you read a report, it may be just written as IA in short form. And when you leave this needle behind in the muscle, you actually don't get any new waveform. It appears relatively like a flat line, which is seen in this picture. It has some voltage, but there are no new action potentials, which are seen when the muscle is not acting. Now, then we ask the person to actually contract that muscle. So let's say the needle is in the biceps and you ask the patient to contract the biceps. Now, each muscle fiber will produce what is called as a motor unit action potential. Some of the surgeons will call it MUPS. So because there are so many muscle fibers within a muscle, many such motor unit action potentials will be seen simultaneously, producing a large noise from the speaker. And we call it an interference pattern. So many motor unit action potentials will join together to form what is called as an interference pattern. So have a look at this video. I'm not sure you'll be able to hear it. So you'll see at rest, there is a straight line there, which represents there is no action potentials at rest. But when I ask the patient to use this muscle, you'll see that the patient has multiple waves. Each of those waves represents a motor unit action potential. So let's look at another concept, which is called as conduction block. A conduction block is usually seen in compressive neuropathies and compressive nerve injuries. A compressive nerve injury is essentially an acute compressive neuropathy. So in early cases of compressive neuropathy, so it can be a carpal tunnel syndrome, a cubital tunnel syndrome, tarsal tunnel syndrome, or whatever, or a compressive injury like a Saturday night palsy, you're going to get on electrical studies something called as conduction block. So let's look at what it is actually. So you know that in the myelinated nerve, the nerve conduction occurs by a process which is called as saltatory jumps. So if you look at this picture, you will see that the action potential propagates from nodes of Ranvier. And then in the demyelinated segment where the myelin is absent, it takes longer for the action potential to propagate. And then action potentials, if strong enough, are generated on the distal portion, and the nerve conduction will occur all the way through. Now this is called as slowing. Why slowing? Because in the demyelinated segment, the action potential could not jump like what is seen in the proximal or in the distal segments along 2 points of nodes of Ranvier. So it took longer for the action potential to propagate. So when you actually check the nerve conduction study, the slowing is represented by what we call as increase in latency. And I'll show you that picture. So when you do a proximal stimulation in such a patient, you will notice that there is what we see as a stimulus artifact, the point at which we did the stimulation. And instead of a short period of latency, you'll find a longer period of latency after which a snap or a CMAP is formed. So this is what is called as increased latency. Okay. But when we actually stimulate the distal portion of the nerve, because the nerve is essentially intact distal to the point of demyelination, you'll find a normal CMAPs and snaps. Now, suppose the demyelination is severe enough, you can have a complete conduction block. In complete conduction block, the saltatory jumps will occur till the point of demyelination. It will try to propagate across the point where it is demyelinated, but may not have enough action potential to actually produce saltatory jumps on the other side. In such a case, when we stimulate proximal to the point of injury, the snaps and CMAPs will be negative. So this is an advanced demyelination or conduction block. You can have this where when you stimulate proximally, you will not have any nerve conduction waves when we measure it off using electrodes. At the same time, when we stimulate distally, because the nerve is essentially intact distally, you will get normal snaps and CMAPs. So let's look at this scenario where we are actually doing 2 points of stimulation on the same nerve and trying to read the CMAPs from the reading electrodes, which are marked as R. Now, if you stimulate there, you'll have a short period of latency here marked by 3 milliseconds, and then a waveform is generated between the two reading electrodes. Now, I will stimulate proximally to the elbow. It takes so much longer from the stimulus artifact. It takes longer because the nerve action potential has to propagate all the way till there. So it takes longer. And then an action potential is generated within the muscle. So this is normal. So the time it took from the stimulus artifact till the formation of the wave is called distal latency for the distal waveform. And the time it took from the stimulus artifact to the formation of the wave, when we did a proximal stimulation, it is called a proximal latency. Now, the difference between the two latency will actually tell you the time it took for the nerve current to propagate from these 2 points of stimulation. And if you can use an inch tape and measure these 2 points, you can actually measure this distance. So now that you know the distance, you know the time it took for the action potential to propagate these 2 points. So now that you know the distance, you can actually calculate what is called as a conduction velocity. So the conduction velocity is simply distance by time. So you know the distance, you know the time it took for the nerve conduction to come from here to here, which is difference between the proximal latency and distal latency. So conduction velocity is basically distance divided by proximal latency minus the distal latency. Now, assume a case where you have a distal point of compression. So what really happens? So the picture which you see there is a normal conduction which we had seen in the previous one. So we'll compare it with that. So now when you actually stimulate distally, because there is a demyelinated segment, it takes longer for it to go across the demyelinated segment and then generate a compound motor action potential. When you do the same stimulation proximally, that same extra time gets added on to the proximal latency also. So basically the distance between the two waveforms are same, but there is an increase in distal latency. So if you have a compression distally, you have an increase in distal latency. And this is one of the common findings which we see in patients with a conduction block or demyelination. So this is one of the different features which we get to see in demyelination. Now, another possibility is, now let's assume, we'll take another example where the compression is occurring proximally. And this is a normal for comparison. So when we stimulate distally, because the nerve segment is normal distally, it will have a normal waveform, normal latency, normal distal latency. Now, in this particular case, unlike the previous cases, all the nerves are not equally demyelinated. That means some have demyelination, some don't have demyelination, some have demyelination worse than the others. So see what really happens. So when we stimulate proximally, you'll find a waveform which is now flattened out. Now, what does this flattening actually show? This part of the waveform has axons which have normally conducted. This part of the axons, subnormal, and this part little more worse, and this part even worse. So you'll find a flattening of the waveform, which is called as differential slowing. So you can either find an increase in latency or you can find differential slowing in patients with demyelination or conduction block. Sometimes the demyelination is significant enough that some of the fibers may not conduct at all. In such a scenario, when you stimulate proximally, distally, because the distal segment, the nerves are normal, you'll have a normal waveform. But now when you stimulate proximally, proximal to the point of problem, you'll find that the waveform actually becomes flattened out. This means less axons are actually conducting normally, while the rest of the axons have complete conduction block. So in this scenario, this ulnar nerve has a partial conduction block because only some of the axons are working properly. In very severe cases, the conduction block can be so severe that all of the axons will not conduct at all. In that scenario, again, when we stimulate distally, you have a normal distal waveform. But when we stimulate proximally, just proximal to the point of compression, you'll find a total conduction loss. So in summary, demyelination can cause prolongation of latency. It can cause a complete or a partial conduction block or differential slowing, as shown in the previous 4 examples. Now, the problem is all of these studies, we are actually comparing the values of proximal and distal latency with some kind of normative values which are present for that particular population, and which is not exactly true. And when we try to do nerve conductions, the nerve conductions are highly dependent on the patient type, weight, age, maybe the dryness of the skin, how tall the patient is, the temperature, and so on. So sometimes when we do the testing on the same patient at different times or at different scenarios, you find different results. So the best way to actually find out if a nerve is actually got a problem with conduction is to either compare 2 segments of the same nerve or to compare the same nerve with an adjoining nerve, like we commonly do in carpal tunnel syndrome. So in this particular patient, the patient has a normal ulnar nerve. So when we do a proximal and a distal stimulation, the patient has normal waveforms. And in this particular case, we want to find out if the patient's got carpal tunnel. And we'll do the same test now that we know the values for both the proximal and distal conductions for the ulnar nerve. We're going to do the same test for the median nerve. So in carpal tunnel, you know that there's a compression distally in the carpal tunnel. And when we do the distal stimulation, you'll find that there is an increase in latency. When you do a proximal stimulation, if there is no problem in this segment, otherwise normal, you're going to get a prolongation of distal latency. So this difference, you're going to find the difference between the latencies between these 2 nerves. And in cases of carpal tunnel, the difference of distal latency of the median nerve versus the ulnar nerve, if the difference is greater than 0.4, that means the patient has carpal tunnel. Okay. Now what happens when the nerve is actually transected? Excuse me. So when the nerve is transected, so till now we were talking about a conductive loss where the axon is not injured and there's only a demyelination over a segment. Now a nerve axon can actually get transected in either an axonotomic or a neurotomic injury, which will be a Sunderland type 2 to type 5 type of injury. So on day 1, when we stimulate proximal to the injury, because the axon is discontinuous, both the snaps and the C maps will continue to be negative. Okay. But when we actually stimulate distal to the point of injury, on day 1, because Wallerian degeneration has not set in, the patient will have normal snaps and normal C maps because the nerve segment is normal on day 1. Okay. And when you pass a needle into the muscle and tell the patient to contract that muscle of whose nerve is actually injured, the patient will not show anything special except for the fact that no motor unit action potentials will be seen because the nerve is discontinuous. If there are motor unit action potentials in a muscle, which is deemed to be paralyzed, then it means that the nerve is not completely injured. In other words, the patient has an incomplete nerve injury. Now, within the first 3 to 5 days of injury, you'll find that the myelin actually begins to degenerate a bit. The axon still stays relatively intact. So when you stimulate distal to the point of injury, you'll notice a slight reduction in the amplitude of the snaps and CMAPs, like the examples we showed before. Now, after 3 to 5 days, Wallerian degeneration would have set in so much that the nerve axon also becomes discontinuous. At this point, when you begin to stimulate distal to the point of injury, there is a sudden loss of both snaps and CMAPs. And this finding, that is, after 5 days, when you do a distal point stimulation and study the nerve conduction test, this is the earliest evidence of degeneration. Okay, so the loss of snaps and CMAPs after 5 days of a transection injury is the earliest evidence of nerve degeneration or nerve transection, in other words. So CMAPs and snaps essentially continue to be present for the first 4 to 5 days after nerve transection. There's a gradual fall in amplitude, and there is no significant fall in the conductive velocity in the first 4 to 5 days. And then there's an abrupt fall in the nerve conduction and becomes a complete conductive loss after 5 days. Now, about a week to 2 weeks later, when you actually stimulate, you'll find all the stimulation things are the same. There's no big difference. Snaps and CMAPs continue to be negative. But when you put a needle into a muscle, what till now was relatively normal suddenly will produce a spontaneous wave, which is called as a positive sharp wave, which is seen in this picture. This is the earliest objective evidence of degeneration. So about 2 weeks down the line, when you get to see the spontaneous waves, these positive sharp waves, we know that the patient has definitely a nerve transection. You can see it in this picture. All those reflected waves are called the positive sharp waves. Now, another week or two later, when you pass a needle into a muscle, this is what you're going to see. Along with the positive sharp waves, you're going to get a new wave, which is a narrow bipolar wave, which is called as a fibrillation wave. And an example of that is what you see here. You can see a fibrillation wave. So what do you see within 2 to 4 weeks of injury? There's an increase in insertional activity, and you get to see these spontaneous denervation potentials, which go by the name as positive sharp waves and fibrillations. And obviously, the patient has no volitional motor unit action potentials. So essentially, in a nerve injury, the best time to do an electrodiagnostic test is after 4 weeks. And please do not order an electrodiagnostic test before 4 weeks. So to summarize, on the first day, distal segment snaps and CMAPs remains normal. EMG insertional activity is normal. There's no spontaneous activity, no volitional activity on EMG. Less than 5 days, mild fall in the voltages, normal insertional activity, no spontaneous activity. After 5 days, sudden drop in snaps and CMAPs, they become absent. Insertional activity still remain the same, but about 2 weeks down the line, you'll find an increase in insertional activity. That means when you pass a needle into the muscle, the amount of insertional activity waveforms increase. You also get a new spontaneous wave, which is called as positive sharp wave. And a couple of weeks down the line, along with the positive sharp waves, you're going to get what is called as fibrillation potentials. Now, what happens after nerve regeneration? Eventually, if the nerve tubes are intact, the axons will grow through the nerve tubes and eventually reach their sensory end organs. And the snaps and the CMAPs tend to be negative for a long time till remyelination occurs. So essentially, snaps and CMAPs are bad tests to do to see if a nerve is actually regenerating or not. But when you pass a needle into a muscle into which the nerve has actually reached, along with the positive sharp waves and the fibrillation waves, which are called as spontaneous waveforms, you're going to get this new polyphasic waves, which is called as a nascent nerve regeneration wave. Now, what you have to understand about nerve regeneration, there are 2 types of nerve regeneration waves which is commonly seen. Now, if a nerve has few axons which are still intact while the rest have undergone Wallerian degeneration, usually which happens in some traction injuries. So what the nerve tries to do is it tries to grow into the territory of the other nerve filament by what is called as collateral sprouting. When collateral sprouting occurs, you get this large polyphasic waveforms in an attempt for the nerve to actually stimulate other muscle fibers too. Okay, so this is different from a nerve which is completely regenerated after the injury and reaches the muscle, where the waveform is of lower amplitude, but again polyphasic. And over time, the polyphasic part of it disappears away and the patient gets a normal motor unit action potentials. So these are nascent waves. You can see in this picture. Small amplitude polyphasic potentials, which means that the nerve fiber has actually reached the muscle and is generating some action potentials within it. Okay, and this is an example where waveforms occur because of sprouting. Polyphasic large amplitude waves. Okay. So what you have to understand, the limitation of electrodiagnostics is that the nerve actually regenerates from a cut end portion roughly at about 1 millimeter per day. So when you do an EMG test, which is probably the best test to study if the nerve is regenerating or not, unfortunately, you will produce no nascent motor unit action potentials until the nerve has regenerated all the way through and reaches the muscle. So unless the nerve reaches the muscle, you cannot really say whether the nerve has regenerated by electrodiagnostic studies. So that's a summary of electrodiagnostics across. I'll just skip this slide. And then I'll introduce one more concept, which probably will come up in the next lecture. And that is in patients who have what is called as a root avulsion injuries in brachial plexus. What you have to understand is that the motor nerves cell body is present within the anterior horn of the spinal cord, while the cell body of the sensory nerve is present within the dorsal root ganglia. So if you have an avulsive injury, the motor nerve actually undergoes Wallerian degeneration from the point of injury all the way down. But because the injury is occurring to the root proximal to the point of the dorsal root ganglion, the sensory nerve is actually intact. So in these patients, when we do the nerve conduction test, you will find that the snaps are preserved and almost normal, while the CMAPs are absent. But the patient still has dense sensory loss because the sensation cannot be conducted to the brain through the dorsal tracts. So an absent sensation and presence of snaps is actually a poor prognosis because such a lesion is usually not repairable in the brachial plexus injuries. Now I'll just run through this. In carpal tunnel syndrome, you know that the contents of the carpal tunnel contains all the tendons, that's the FTP, FDS, and the FPL tendons. It also has a flexor tenosynovium, which covers these. And it obviously contains the median nerve. Now, the pathophysiology in a carpal tunnel or any compressive neuropathy is, it starts as a focal demyelination. Because of prolonged compression, some part of the nerve will undergo focal demyelination. And then it can go on to form diffuse demyelination. And if the compression stays on for a very long time, the patient can have even axonal degeneration. And we'll just look at them as examples. I'll run through this slide too, because you know these things. In early stage, you have pins and needles sensations, usually brought on by activities. In the intermediate stage, when there is partial demyelination, the symptoms are present both in the night and in the day. And late stages, there is significant sensory and motor loss. And paradoxically, because there is a sensory loss, the patient has not significant symptoms. And patient may even have wasting of the abductor pollicis brevis, which is generally seen in some patients. You know the provocative tests, I won't go through that. So this is what we typically do for a patient with a carpal tunnel. So this is actually called the Boston Questionnaire for Carpal Tunnel, which we modified for the Indian population and it's been published. So in this particular chart, what you're going to see is the assessor has actually written 2 grams here, when the normal sensation should have been 0.2 grams. You'll notice on the right side, the patient can only perceive 2 grams and no weight smaller than 2 grams. So the patient has actually lost sensation in those 3 fingers. So you know those tests. I'm not going through that. As far as electrophysiology is concerned, these are the things you have to remember. So if you have a distal motor latency which is greater than 4.2 milliseconds, a distal sensory latency greater than 3.5 milliseconds, a nerve conduction velocity which is less than 49 meters per second, or a latency difference between ulnar and median which is greater than 0.4 milliseconds, generally we say the patient has some form of carpal tunnel. They're generally classified as mild, moderate, severe based on what all are involved. So if only the sensory nerves are affected, we call it mild. If sensory and the motor nerves are affected, we call it moderate. And if it actually causes axonopathy, that means there's axonal damage, which can be shown as either a decrease in amplitude of the waveforms or the presence of fibrillation or positive shock waves as you needle the muscle, then you call it a severe carpal tunnel. We'll look at some examples. So here's a patient who presented with carpal tunnel symptoms. You'll notice in this particular case, it's kind of unusual. The C maps show a value which is higher than 4.2, that is 5 and 4.6 milliseconds. But strangely enough, the sensory nerve action potentials, the latency is good. It is less than 3.5 milliseconds. This is kind of an unusual finding. Usually the sensory nerve is first affected, followed by the motor nerve. But what is important, what the instrument actually picks up is, in both those cases, on both the hands, left and the right side, the latency, distal latency difference between both the median and the ulnar side is greater than 0.4 milliseconds. So we will classify this as a moderate carpal tunnel because both sensory and motor nerves are affected on both sides, and right side is more involved than the left side. Another example, there is increase in latency, distal latency of both the right and the left side. There is increase of latency of the sensory nerves both on the right and the left side, also with a fall in amplitude. And you also notice that the latency difference between the median and ulnar nerves is more than 0.4 milliseconds. So again, this patient has a moderate carpal tunnel syndrome, right greater than left. Third patient, similar findings. You'll find that on the right side, the motor latency is quite high and the sensory latency is completely, the sensory conduction is completely absent. So there is no response to stimulation of the sensory nerves. And you'll find that there is some increase in the difference on the left side, 0.8 milliseconds, but there is no conduction. So you cannot find this difference in value on the right side. So patient basically has, on the left side. So the patient in this case has a severe carpal tunnel on the left side and a mild carpal tunnel on the right side. So here's another patient. Both the motor as well as the sensory nerves show no response to stimulation. That means there's a complete conduction block. And when we put a needle into the muscle on that particular side, into the abductor pollicis brevis, we found that the patient is actually developing spontaneous potentials, namely fibrillations. So anytime the patient has fibrillations or positive shock waves, you know that it's no more a myelin problem. It's no more a conduction block. It has gone on to the stage from just a conduction block to a axonopathy. So this patient has a severe carpal tunnel on the right side and a moderate carpal tunnel syndrome on the left side. So what we have to understand is about 10 to 15% of the patients with carpal tunnel have normal electrodiagnostic studies. And like I mentioned, the values can change based on the age, height, weight, quality of skin, temperature, and the way we have prepared the skin when we do this particular test. So it's better to compare on the same patient 2 different nerves passing side by side rather than comparing it with absolute values like I just showed, 4.2, 3.5, and so on. Now, the second thing you have to remember is the diagnosis of compressive neuropathy is actually a clinical one. And the electrodiagnostics is purely corroborated. So for those of you who are PGs in this group, I would urge you to actually go up and look at this particular test, which is called as the CTS-6 test. So basically this test has 6 different portions and you're going to score it. And the strange thing is in all these 6 things, you'll notice that the patient, there is no electrodiagnostics in any of these 6. So what you have to understand, to diagnose a compressive neuropathy, you actually don't need electrodiagnostics. Electrodiagnostics can be reserved for patients who are actually going for surgery because you'll have a baseline which you can compare to if you have an untoward incident during surgery or when there is a doubt. Okay. Another caution is to understand that the median and the ulnar nerves, can have contacts between each other. There may be an anastomosis between the median and the ulnar nerves. So you can have what is called as a Martin-Gruber anastomosis. Basically, somewhere in the forearm, some of the fibers, motor fibers from the median nerve may pass through the ulnar nerve. And so you may get a different set of waveforms which are seen on the left side. I will not go into details on that because that might confuse you. Basically, the electrodiagnostician should be aware that the median and the ulnar nerve can have these anastomosis, and you might find strange waveforms which you would not probably expect in a patient who's got a compressive neuropathy. So I'll skip through that too. So we know the management of compressive neuropathy, at least a carpal tunnel can be either an open carpal tunnel release or endoscopic carpal tunnel release. Most of you would have seen an open carpal tunnel release. We just call it by the short form OCTR. An endoscopic carpal tunnel release, the incision is smaller. It's placed proximal to the palm, so you don't have a sensitive scar along the palm. So that's a good advantage. The problem being you'll have to have this expensive equipment to do it, and it takes a lot of training to get there. Nerve palsy management, on the other hand, the things you need to ask is, if a patient presents to you with a nerve paralysis, the first thing you're going to find out, is there a history of injury? And a small proportion of patients who actually present to orthopedic or plastic surgeons may be patients who are not our patients, in the sense that they don't have an injury. They may just present to you with a nerve palsy, which may be a demyelinating neuropathy or a polyneuropathy or any other neuropathic condition for which we don't have a surgical solution. So if the answer to that is no, then you have to do a detailed history and a clinical examination, rule out spinal cord, upper motor neuron lesions, and so on, do a comprehensive EMG and NCS test, nerve ultrasounds if appropriate, and definitely ask a neurologist for an opinion. Now, if there is a history of injury, the first thing you want to know is whether it is an open injury or whether the patient had an open injury which produced this paralysis. Now, when you have an open injury, it almost always means that the nerve is transected. In other words, the patient has a neurotemic or a Sunderland type 6 type of injury, type 5 type of injury. So once you know that the patient has an open injury, the next question you're going to ask is, what is the time since the injury? Is it beyond the critical limit of delay? If the answer to that is no, then you can go ahead and do a nerve repair. The patient presents to you a little late. Because the nerves cannot be brought together, nerve ends cannot be brought together, you might have to do a nerve grafting. If the patient presents to you months down the line or years down the line, that means he's come beyond the critical limit of delay, then you may not be able to do a nerve surgery. You may have to do a tendon transfer to balance the paralysis. If the answer to the original question, does the patient have an open injury or not? If the answer to that is no, so it means that the injury to the nerve is usually a compressive or a traction injury. So you're going to wait for recovery. Usually neuropraxic injuries will recover by about 6 weeks, sometimes as late as 3 months. If in this period, you're going to look for progression of a Tinel sign. That means whether the nerve is regenerating along the course of the nerve, whether the axon is regenerating along the course of the nerve. And once it reaches the muscles, whether there is a progression of the motor march. If there is a progression of the Tinels, and if there is a good motor march, all you have to do is wait and serially examine the patient. However, if you're serially seeing the patient at least 1 month apart and you find that this is not a neuropraxic injury, you thought it was an axonotomic injury, but there's no progression of TNLs and there is no motor march in cases where there is motor march, then it is justified in doing an electro-diagnostic study. Now, an electro-diagnostic study, if it's done at 3 months, and you find that there is no collateral sprouting, those large waveforms which you saw, it means that the patient has a grade 3 Sunderland or above type of injury. What it really tells you is such a patient will not recover spontaneously. And then it'll be nice to do a high resolution ultrasound to pinpoint the level of the injury. And if there's evidence of neurotemesis, you go ahead with a nerve surgery. If the patient, regardless of whether it's open or closed, presents beyond the critical limit of delay, then you cannot do a nerve surgery, because even though the nerves will regenerate all the way to the motor end plate, after 18 months, the motor end plate will degenerate. And so the muscle will not recover. Better to do a tendon transfer surgery. What is common for all surgeries in the nerves, while we're waiting for surgery or recovery, you have to do contraction prevention therapy and splinting so that the patient does not develop a deformity. So the role of electrodiagnostics in nerve injuries in an open case actually is kind of limited. So if a patient comes to you with a laceration and he has an obvious median nerve, radial nerve, or any kind of peripheral nerve paralysis, there is no need to do an electrodiagnostic study. You can take him right away into theater, explore the nerve, repair whatever skeletal structures and other soft tissues are there. Along with it, repair the nerve, provided you can provide a good soft tissue envelope. If there's a problem with the skin, like in cases of fracture too, the first priority is to stabilize the bone and then provide a good soft tissue cover like a flap. Go back and do a nerve surgery at a later date. In a patient who comes to you late, typically what we see in our practice, he's had an open injury, somebody assaulted him, or he had a glass cut injury. We know that the nerve was transected, but he comes to us many months down the line, and he does not have an operative notes or a discharge summary which says that the nerve was also repaired. So then it is possibly a good idea to go and do an electrodiagnostic test. Now, what does the electrodiagnosis actually do? When you do the EMG, you're actually looking whether those muscles have fibrillations and positive shock waves. That means the end plates are still working. If they are working, and if the patient is within the critical limit of delay for surgery, then go ahead and do nerve surgery. Nerve surgery means either neurorephy or nerve repair or nerve grafting. If for some instance, the fibrillations and positive shock waves are absent, then there's actually no point doing nerve. So in closed injuries, what does an EMG actually help? An EMG can actually differentiate a conduction block from a nerve transection. It cannot tell you axonotomesis from neurotomesis by one examination, but it certainly can tell you if this person has demyelination versus axonotopic injury, especially if you do the test after 4 weeks. In these patients, if you do an electromyography after 3 months and you find that there is no evidence of collateral sprouting, that means the traction injury is so severe, then you should think of a grade 3 or above injury and should consider some type of nerve surgery for this patient. In patients who are getting re-innervated, either following surgery or spontaneously, electromyography can actually identify re-innervation 1 or 2 months even before grade 1 clinical recovery. So in that way, it is good. But unfortunately, re-innervation can only occur after the nerve has grown all the way and reached that muscle. Okay. So nerve conduction studies, unfortunately, are not a good predictor for nerve recovery, although you can say nerve injury, not for nerve recovery. So what are the different types of nerve surgeries we do? We can do a direct nerve repair in a patient with a nerve injury. You can do a nerve grafting if the patient presents to you late after a nerve transection, where you cannot bring the nerve ends together. And in patients like those in a brachial plexus injury, we do what is called as a nerve transfer, where we take a fascicle of a working nerve which is going close to the nerve which is injured, and then connect it to the branch of this paralyzed nerve to get back focused recovery of one particular muscle. Okay, we look at some examples. So here's a patient who's come with a laceration across the palm, a zone 3 flexor tendon laceration involving the middle and the ring fingers and maybe the index finger. So after doing the tendon repairs, you'll find that the branches of the median nerve, after the median nerve crosses the carpal tunnel, it forms the proper and the common digital nerves. You'll find the branches are injured, while the recurrent branch, which is a motor branch going to the thenar muscles, is relatively intact. So this patient has a normal opponents and abductor pollicis, while he lost sensation in all the median nerve innervated fingers. So because the patient presented early, you can do a direct neurography under the microscope. Some patients may present like this. No median nerve conduction. They have what is called as a neuroma in continuity, which is actually a scarring. So it usually means a type 3 or a type 4 type of Sunderland injury. And if there is no nerve conduction across this, you have to take down that neuroma and put a nerve graft across that particular segment. Here's another patient. This is seen under low power operative microscopy. So the cut end of the nerves will have what is called as a glioma on the distal portion and what is called as a neuroma in the proximal portion. You splice the neuroma like a bread slice 1 millimeter apart. So in the first slice, what you'll notice is the fascicles are not very evident in this slice. That means there is some endoneural and epineural scarring which is present here, and you can't see the fascicles. The moment you cut beyond that, you'll notice many fascicles in the nerve. Now this nerve can be coapted to that portion after you slice on the other side using nerve grafts. This is a neurography done under an operating microscope. This is a 9-0 ethylon. You typically use 2-0 or 3-0 ethylons to suture your skin. We use a 9-0, the same nylon, but with a smaller needle. You can use it and do the neurography. Here's an example of a patient who's undergone a nerve grafting. Somebody who's presented late will find that the defect is so large, few centimeters long, and each of those is a cable of sural nerve, which we have cut, included a group of fascicles on one side and connected it to the corresponding fascicles on the other side. So this is called a group fascicular nerve grafting. Another patient presenting late. This has been marked. So the neuroma and the glioma has been marked by the sonologist before surgery. When we opened, we found that. So the neuroma proximally contains scar as well as a nerve tissue, and glioma distally, which essentially has no nerve tissue because all the nerves have undergone Wallerian degeneration. You cut this down till you find empty nerve tubes distally. Cut this down till you find good fascicles proximally and bridge it with a nerve graft. This is a method by which how we take sural nerve grafts. So this is the back of the leg. We make 3 or 4 small incisions, loop the nerve, gently tug at it distally, find where the tug is, identify the nerve here and go up proximally and deliver the whole sural nerve out. So sural nerve is a large, long cable, roughly measuring about 42 to 45 centimeters. So based on the gap, you will splice this nerve into multiple segments and fill up that defect, which you see in this particular nerve. So same patient, multiple nerve grafts, which have been sutured, and then we applied some nerve glue. So what really happens in the nerve graft? Because the nerve graft is no more connected to the its own cell body, the axon within the nerve graft will undergo Wallerian degeneration, leaving behind empty nerve tubes. These empty nerve tubes will act as conduits through which nerve can regenerate from the proximal cut portion through these and go on to the distal portion. Okay, so that's the ideology of doing nerve grafts. So in summary, what can electrodiagnostics actually establish? So it can establish certainly a conductive loss across a segment of the nerve. So if a patient comes to you and says he's got a particular muscle or a nerve paralysis, you can easily know whether he's malingering or not by simply doing an electrodiagnostics test. You can certainly differentiate conductive loss from nerve transection. That we showed you different examples. Nerve transection will typically show fibrillation and positive sharp waves by the end of 4 weeks. And you can certainly differentiate partial nerve injury from a total one when you do electrodiagnostics. Just like in a clinical examination, based on the number of muscles, the patterns of muscles which are involved, you can kind of tell the patterns of muscles which are injured by needling different muscles by doing electrodiagnostics and establish where the injury can be. And it can identify reinnervation of a muscle a month or two before clinical recovery. Okay. And like I mentioned in the brachial plexus case, you can identify root avulsions by having normal snaps and absent sensations, provided there are no distal nerve lesions within the same nerves. Unfortunately, it has its limitations. It cannot actually differentiate neurotomesis from axonotomesis by doing one examination. And as far as the surgeon is concerned, we want to diagnose a neurotemic injury because the neurotemic injury is the one which actually needs surgical repair. Axonotomic, at least grade 2 Sunderland, and sometimes grade 3 Sunderland will recover by itself. It cannot really predict recovery, although some books say that it can, but I'm not sure it can really predict recovery, but it can kind of grade the level of injury. And unfortunately, it cannot say if the nerve has actually regenerated until the nerve finally reaches the muscle. So for an example, the patient has a radial nerve injury following a humeral fracture, and all the evidence says it's an axonotomic nerve injury. Patient comes to you at 2 months and wants to do an electrodiagnostic test to say whether the nerve is regenerating or not. You actually cannot. You have to wait that whole 5 to 6 months for the radial nerve to regenerate from the spiral groove all the way up to the brachioradialis before the needle will actually pick up reinnervation nascent potentials. So I'll stop there. And I'd like to thank you all for taking your time out to come and listen. Special thank you to the office bearers of the Tamilnadu Orthopaedic Association, specifically the president, Dr. Thirumalai Swami, and the secretary, Dr. P.T. Saravanan. Dr. John Santoshi, a good friend of mine, who agreed to moderate this particular session, and the academic committee, Dr. Vetravel, Professor Thanappan, Professor Suresh Kumar, Professor Thirunarayanan, and Mr. Naresh from Alembic. I'll welcome any questions from the group. Thank you.
Thank you, Dr. Anil. It was a very good presentation as usual. There are a couple of questions. What protocol would you recommend when you have a patient with a fracture humerus with radial nerve palsy?
So our practice in our tertiary setup may be slightly different from yours. So here are the things you can actually do if it is a radial nerve palsy which developed when you were doing the surgery. You have done a plating and you are sure that you did not crimp the nerve under the plate. You were very careful, but the patient developed radial nerve palsy after the surgery. Those cases, it is worthwhile wait and watch. You can certainly wait till 3 months, do your electrodiagnostic test. And if it doesn't show collateral sprouting at that point in time, it's a good practice to actually send it over to a nerve surgeon who can deal with it better. A good high resolution ultrasound, provided you have a sonologist who can tell you the condition of the nerve, provided you have an ultrasound with a good high frequency probe, it can tell you the status of the radial nerve, whether it is sitting under the plate, whether it's damaged, and so on. In a practice for nerve surgeons like us, unfortunately, we have different sets of patients who are coming from different countries, maybe from different states, and all of them don't have all the documents with them. So sometimes the patient wants to know what has really happened to the nerve. So the question is, should we go unnecessarily and operate and explore the nerve? Maybe the answer to that is also yes, provided you are somebody who can handle a nerve and not damage the nerve at all. Okay. Now, there are some controversies about what happens if you develop a Holstein-Lewis fracture, and so on. So the present evidence is most radial nerve palsies will recover by themselves, and those that does not show electrical evidence of recovery, like what I mentioned, collateral sprouting by 3 months and so on, or if you have access to a high resolution ultrasound during the time, they're the only ones which actually require surgery. Okay, does that answer your question?
Yes, sir. One thing that I think the postgraduate wanted to ask is, how long should we wait when you have, I think he wants to know if in closed humeral fractures with radial nerve palsy, how long should we wait before proceeding with the electrodiagnostic studies?
Yeah, so two things you have to understand. One is, presume that you have done the surgery and you're damn sure that you have not damaged the nerve, you have not cut the nerve during the surgery. If you are sure. If you're not sure, better to send it over to somebody who can actually explore it or investigate for it. So if you're sure that you have not injured the nerve, then what you need to do is, remember, brachioradialis recovery, which is the first muscle which is going to recover, may take 6 to 7 months for it to actually show clinical recovery. So the problem is, if you have actually transected the nerve and waited for 6 to 7 months, and then the person goes to some place and the surgeon says the nerve was cut or the nerve is sitting under the plate, then you lose your reputation. That is the first thing you have to understand. What you can do is, from the second month, you can follow up the patient monthly and see if the TNOA is actually progressing distally or not. Because you are not going to get a motor march till the nerve reaches brachioradialis, which is 6 or 7 months away. So if the TNOA is not progressing at a rate of at least 1 inch a month, or you're doubtful whether it's progressing, you can see the patient again after 1 more month and see if the TNOA has progressed distally or not. So this requires good outpatient charting. So the best way to do it is measure the point of maximum TNOA from a bony endpoint, let's say the lateral epicondyle, measure it and write it in your OPD records. The next time he comes, the TNOA should have progressed by at least 1 inch distally. If you are unsure about it, then better to do both electrodiagnostics and, if possible, a high resolution ultrasonography. Okay. So a patient can have, let's say, ulnar nerve in the arm following some injury. By the time the nerve regenerates from the arm and reaches all the way to the hand, it may take more than a year. So you can't wait a year and then say, the nerve, I don't have intrinsic recovery, and I waited, I watched, and it didn't come. So that is, basically the whole point about following up a patient with nerve injury is to do serial examination. Unfortunately, the patient has been operated by you, he will be kind of rebellious, he'll be unhappy, he will say you did it, all those things will happen. But reassure the patient, see what is best at that point in time. If you have a progressive TNOA, rest assured, the chances of recovery is high. If the TNOA does not progress, better to send it over to somebody who can manage the case. Okay.
There's a similar question of what to be done in case of Erb's palsy. I mean, how long do we wait after patient presents to us for electrodiagnostics test?
Yeah. So I know typically we do Erb's palsy, patients go on for electrodiagnostic tests and so on. The minimum you have to wait, I would say, is at least 3 months to do an electrodiagnostic test. But from a surgical standpoint, there is a little bit of controversy of how long to wait. So generally, when we were training, it was believed that you can wait for up to 5 to 6 months to see if clinical recovery occurs in the shoulder, abduction, and biceps. That is elbow flexion. So if both of this occurs by that particular point in time, probably there is no point in waiting, doing anything or doing an intervention. That has not necessarily given us good outcomes. So more and more Erb's palsies, or not Erb's palsy, I'll say obstetric brachial plexus palsies, are now being operated because the chance of cross innervation, that means nerve fibers from one root will go into the other root distally or into the cords and trunks which are not supposed to be supplied by that root, and the patient begins to get co-contractions. That means when the biceps is acting, the triceps also begins to act. And what it means is the patient will not have any elbow flexion. So many surgeons actually believe that you can actually intervene early so that you repair, neuralize all these nerves quite early. But in our practice presently, clinically, we can wait for up to 5 to 6 months to see if there is a biceps or a shoulder abduction recovery. There is no recovery in that time, then you can do all your tests, including MRI and electrodiagnostic tests.
I think one question which was asked pretty early in the presentation was what changes will we have in the nerve studies if they are performed on the day of nerve injury?
So I don't know if you had logged in at that point. Let me see if I can still share my screen. So you see this. On day one, can you see my screen?
No, we cannot see a screen.
So on day one, if you stimulate proximal to the nerve in a nerve transection, because the nerve is discontinuous, the snaps in the CMAPs, nerve conductions will be negative. There will be no snaps and CMAPs. But if you stimulate distal to the point of injury, because there is no Wallerian degeneration occurred yet, the patient will have normal snaps and CMAPs. So the problem of doing this test on day one, whether the nerve is transected or whether the person has significant demyelination, you cannot differentiate the two. So in other words, it is worthless doing a electrodiagnostic study on day one. So like I mentioned, the best time to do an electrodiagnostic study is probably after 4 weeks. By 4 weeks, not only the snaps and CMAPs will be absent distal to the point of injury when you stimulate it, you will also have established positive sharp waves and fibrillation waves. These are called as spontaneous potentials, which are present only if the axon is damaged. Okay. So the best time to do an electrodiagnostic study is after 4 weeks. Please do not order one before that. Okay.
Next question is there a role for ulnar nerve repair if it is injured proximally, say in the forearm? What are the chances of recovery?
Yeah, so certainly if the ulnar nerve is injured in the forearm, we should repair it or graft it. The reason being, when we actually do this ulnar nerve repair, remember there are two components to the ulnar nerve. There is both the sensory and a motor. So the chances that the patient gets back sensory recovery in the ulnar nerve distribution is quite high. Although chances of motor recovery is about 50% chance that he will get motor recovery for the intrinsic if the injury is proximal to the middle of the forearm. So if you actually read through literature which has come over the last maybe 15 to 20 years, there is something called as nerve transfers. So nerve transfer, there are different types. I don't want to confuse you. What is done is, one scenario is you take the anterior intraosseous nerve branch, which is going to the pronator quadratus, and you connect it to the motor part of the ulnar nerve. because the anterior introitious nerve to the pronator quadratus is very distal, the chances of intrinsic recovery is high, provided you do the surgery early enough. The rest of the nerve can be repaired or grafted high up. Another way to do it is take this nerve, the same anterior introitious branch to the pronator quadratus, and give it end to side to the motor branch of the ulnar nerve. So what it does is some of the fibers through the the deep branch of the ulnar nerve will grow through and innervate all of your intrinsic muscles. May not be enough to cause clinical recovery, but enough so that there is some voltages which will be passed across the motor end plate. So the motor end plate will be kept alive longer, that if now you have done a primary nerve repair or grafting high up, by the time those nerves reach here, the motor end plate is still alive for it to receive those axons. The problem with this surgery is that we have not had consistent results over the board across surgeons. So although there's a group of surgeons saying we've got great results, we've not been able to actually see it in our own practice and not in many of the surgeons who I've met either. So it is not a very popular surgery yet. But to answer that question in brief, will you repair any mixed nerve, even if it's a high injury? The answer to it is yes. Even if you don't get a motor recovery, certainly you'll get some sensory recovery. Because even up to 5 years, the sensory nerves can grow back and give you back protective sensation to the fingers or foot or hands or toes and so on. Okay.
I think you have answered all the questions now, because you answered about mixed nerve injuries also, and also about tendon transfers to be combined along with nerve injury.
Yeah.
I think the one last question which is seen here is grade 2 or grade 3 injury, the critical period duration for repair.
What you have to understand about repair, nerve repair or nerve grafting, the earlier you do it, the better the outcome. So day one repair of a nerve gives you the best outcome compared to any other repair which is done down the line. Now the word critical limit of delay basically is the longest you can wait before you attempt any kind of nerve repair surgery. So there are two times you have to understand when you talk about critical limit. So let's say T, big capital T, is the critical limit for delay. That means that's the longest you can wait in months, after which if you do a nerve repair or grafting, patient will not have clinical recovery. And that critical limit of delay depends on where the nerve is injured, because nerve takes time to also regenerate. So from the point of injury, let's say that the nerve takes small t, the amount of time in months for it to regenerate to reach the muscle. Okay. So both these times, the capital T, that is a delay, plus the time it takes for regeneration, the small t, should be less than 18 months. Okay. So if this sum of these two values is more than 18 months, then the possibility of you getting that particular muscle recovery is very poor, because 18 months is the time beyond which motor end plates will degenerate substantially. And even if the nerve reaches the motor end plate, it will not conduct across the motor end plate. So although if you read the books, they will tell you for a distal lesion, the critical limit of delay is around 12 months. And typically for proximal lesions, the critical limit of delay is somewhere between 6 months to 9 months. That is the latest you can wait, after which surgery is not useful. You can actually calculate it based on number of months very easily from the motor end point of a muscle. If you use an inch tape and measure it, you can kind of say what is the critical limit for each type of nerve injury.
I think there are no more questions.
Yes.
We had a very nice session with Dr. Anil today, and he gave us a lot of real life examples from his own work. And I think that's the strength of his presentation, that he does it himself. And so he is able to share his experience both surgical as well as the diagnostic part. So thank you, Dr. Anil, for the
Thank
very
you.
nice presentation.
Thank you, Dr. John, and I thank again the office bearers of the Tamilnadu Orthopaedics Association. A special thank you to Dr. P.T. Sarvanan for helping organize this and the academic coordinators. And thank you, Mr. Ramesh, for bringing us all together. Okay.
Thank you so much, sir, Dr. Anil sir, for this wonderful lecture. It's a very rare topic, and you covered everything from the basic to the advanced parts of this topic. Thank you so much, and I also thank Dr. John Santoshi for the session. Graduate for this program. With this, we will close this program. We will meet coming Friday for another session. Thank you all.
Thank you, sir.
Thank you, sir.
Again, thank you so much, sir. Good night, sir.
Good night.
Yes, you can close.